Historical context: the national deinstitutionalization trend. State-run psychiatric hospitals were once the primary providers of long-term mental health care in the U.S., peaking in the 1950s with around 559,000 inpatient beds nationwide. By the 1990s, this number had plummeted to about 40,000, a roughly 92% reduction, as facilities closed or downsized dramatically. This wasn't isolated to Oregon. It happened across nearly every state, driven by a combination of factors: policy reforms and federal incentives. The Community Mental Health Act of 1963, signed by President Kennedy, aimed to shift care from large institutions to community-based centers, supported by new antipsychotic medications and civil rights advocacy against abusive asylum conditions. Federal funding encouraged states to deinstitutionalize, but promised community resources were chronically underfunded. Only about half of the planned 2,500 community mental health centers were ever built. Budget pressures and cost shifting. States faced rising costs for institutional care amid economic shifts in the 1970s-1980s. Many closed facilities to cut expenses, relying on Medicaid and other federal programs to fund outpatient alternatives. However, this often meant discharging patients without sufficient follow-up, housing, or treatment options. Examples: across states, closures mirrored Oregon's timeline, e.g., Damesh in 1995. Nationally, facilities like Topeka State Hospital, Kansas 1997, Metropolitan State Hospital, Massachusetts 1992, and Allentown State Hospital, Pennsylvania 2010, shut down in similar waves. By 2023, many states had fewer than 10 state-operated psychiatric hospitals left, with total public beds dropping to historic lows. In Oregon, the closure of Damesh, opened in 1961 and shuttered amid reports of inhumane conditions, exemplified this, releasing patients into communities ill-equipped to support them. The state's Eastern Oregon Psychiatric Center in Pendleton closed in 2014, further reducing capacity. Today, Oregon has only about 743 state hospital beds for adults, with even fewer staffed. How this contributed to the national homeless crisis. While deinstitutionalization wasn't the sole cause of homelessness, factors like affordable housing shortages, poverty, and substance use disorders play major roles. It undeniably exacerbated the issue by leaving many with severe mental illnesses without stable support. Here's how the evidence connects the dots. Discharge without adequate safety nets. Many patients were released from institutions with minimal planning. Nationally, the lack of community mental health funding meant former inpatients often ended up cycling through emergency rooms, jails, or streets. Studies show a direct correlation. As hospital beds vanished, homelessness among the mentally ill rose, with estimates that 25–30% of homeless individuals have severe mental illnesses, like schizophrenia or bipolar disorder. In Oregon, around 40% of the homeless population has a serious mental illness, higher than the national average, and closures like Damesh directly led to increased street homelessness in Portland in the 1990s. Rising homelessness statistics. U.S. homelessness hit a record 771,480 people on a single night in January 2024, up 18% from 2023 and 40% from 2018. Chronic homelessness, long-term, often with disabilities including mental illness, surged 73% over the same period, from 97,000 to 168,000. About 22%, 140,000, of homeless adults in 2024 met criteria for serious mental illness. Researchers attribute part of this to deinstitutionalization's trans-institutionalization, where people shifted from hospitals to prisons or homelessness. Broader systemic failures. The affordable housing crisis amplified the impact. Median rents outpaced wages, making stable housing unattainable for those with mental health challenges. In states like California and Oregon, this led to visible increases in unsheltered homelessness, 36% of the total in 2024. Oregon's experience echoes this. Without enough community treatment or housing post-closures, many cycle between the Oregon State Hospital, jails, and streets. Nationally, experts note that while deinstitutionalization aimed for better outcomes, Underfunding turned it into a system designed to fail. Key nuances and ongoing implications. Not every closure was detrimental. Some states maintained or repurposed facilities, and advances in outpatient care have helped many. However, the national bed shortage, now about 50 per 100,000 people, far below the recommended 50-60, leaves gaps, especially for acute crises. In Oregon, this manifests in long waits for care and over-reliance on emergency departments. Recent federal efforts, like executive orders promoting institutionalization for homelessness reduction, highlight the debate. Some advocate for more beds, others for better community funding to prevent crises. Overall, Oregon's closures are a microcosm of a national policy that prioritized deinstitutionalization without the necessary infrastructure, directly fueling homelessness by stranding vulnerable people. If you want to dive deeper into this topic, sources like HUD's annual homelessness assessment reports or AMA ethics journals provide robust data for further exploration. Welcome back to Healthcare in America. Over the next 3 episodes, we're going to look at urgent care, not the kind you schedule, not the kind you shop for, the kind that doesn't wait. In the first episode, we'll explore what urgent care actually is and what it isn't. We'll see how immediacy changes the rules, compresses choices, and forces decisions that no one wants to make lightly. In the second episode, we'll look at what happens when systems designed for efficiency are suddenly forced into urgent, unpredictable situations. We'll see where bottlenecks appear, where workarounds become routine, and how pressure spreads across the system in ways that aren't always visible. In the third episode, we'll ask a simple but important question. Who carries the consequences when care can't wait? Patients, families, frontline providers, and communities all bear the load, often quietly, without recognition. At the end of the 3 episodes, we'll pause to reflect on why this reality is so difficult to talk about honestly. No solutions, no slogans, just a clear look at what happens when care is unavoidable. This series isn't about pointing fingers or making policy. It's about understanding what exists so we can see the system clearly before we decide what to do next. Let's begin.
What urgent care actually is and is not. Welcome to the first episode of Healthcare in America, When Care Can't Wait. Today, we're going to look at what urgent care really means and what it doesn't. Most of the time, when we talk about healthcare, we think about appointments, schedules, and choices. But urgent care isn't optional. It doesn't wait for comfort or convenience. It arrives whether the system is ready or not, and it changes everything. Urgency collapses options. Decisions that would normally take days, weeks, or months are compressed into minutes or hours. There's no time to compare prices, shop for the best facility, or negotiate who sees you first. Consent still exists, but it's constrained. Choice becomes secondary to need. Triage replaces preference. Clinical judgment determines who gets attention first and who waits. Resources are allocated, not selected. What begins as exception, a single patient needing immediate attention, can quickly become the new normal because urgent care is cumulative. Emergencies don't happen in isolation. Chronic neglect, unmanaged conditions, and mental health crises feed into the system until every gap becomes a pressure point. At its core, urgent care is about responsibility. Someone must act. Delay itself is harm. And yet, the system doesn't pause to announce this. The ethical load is quiet, invisible, and heavy. In this episode, we're not going to talk about costs, insurance, or policy solutions. That comes later. Today is about observation, about noticing how care behaves when it becomes unavoidable. If this episode feels incomplete, that's intentional. Because urgent care itself is incomplete by nature. It demands action before understanding. By the end, I hope you'll see urgent care not as an anomaly, but as a lens, a way to understand the pressures, constraints, and human work that sustain healthcare when waiting isn't an option. What urgent care actually is and is not. When systems built for efficiency meet urgency. Welcome back to Healthcare in America. when care can't wait. In the last episode, we explored what urgent care actually is and what it isn't. Today, we're going to look at how systems designed for efficiency and predictability respond when urgency shows up uninvited. Most healthcare systems are built around averages. Schedules, staffing, and workflow all assume a level of predictability. Efficiency depends on forecasting, and forecasting depends on stability. But urgent care doesn't follow a curve or a plan. It arrives in spikes, in crises, in moments that no one could schedule. And when that happens, even the best designed system starts to strain. Bottlenecks appear immediately. Staff are limited, physical space is fixed, and specialized resources can't be conjured out of thin air. What begins as a minor delay can cascade into something much bigger. Temporary workarounds, hallway beds, boarding patients, delayed transfers start to look permanent. What was supposed to be exceptional quietly becomes routine. The hidden costs of making the system work under stress are not just financial, they are human. Providers carry moral and emotional weight. Burnout rises, errors increase. Decisions once carefully considered now have to be made in compressed time, with imperfect information. Urgency also exposes upstream failures. Preventive care that didn't happen shows up as crisis. Mental health needs that were deferred now land in emergency rooms. Chronic conditions unmanaged become acute. The system absorbs what the rest of the infrastructure failed to address, but it does so imperfectly, at a human cost. And yet, on paper, it looks like control. Metrics suggest management. Dashboards track throughput. Administrators and observers can say the system is functioning. But what they are really seeing is workarounds, improvisation, and quiet suffering. Throughput becomes the proxy for success, and the deeper pressures remain invisible. We're not here to point fingers or propose solutions. Today is about noticing behavior under pressure, seeing where the system flexes and where it strains. Because only by understanding this can we begin to grasp the consequences when care can't wait. In our next episode, we'll explore exactly that. Who absorbs the consequences when the system can't flex enough? And what that looks like for patients, families, providers, and communities. Stay with us. When systems built for efficiency meet urgency. Who absorbs the consequences when waiting isn't an option? Welcome back to Healthcare in America, when care can't wait. So far, we've looked at what urgent care actually is and how systems designed for efficiency respond under pressure. In this episode, we turn to the people, the ones who carry the weight when care can't wait. Urgency does not distribute impact evenly. Some patients are more vulnerable than others. Some families are better equipped to navigate complexity. And some communities have far fewer resources. The system doesn't decide this intentionally, it just happens, quietly, invisibly, and sometimes tragically. Patients absorb uncertainty. Decisions are made with incomplete information. Recovery doesn't end at discharge. It continues at home, often with guidance that is partial, confusing, or hard to follow. Financial exposure, where it exists, is deferred but rarely avoided. Patients bear responsibility for a system that cannot fully hold them. Families become care coordinators by default. They manage transitions between facilities, interpret medical instructions under stress, and fill gaps the system cannot or will not cover. This work is essential, unpaid, and largely invisible, yet it is critical to outcomes. Frontline providers absorb moral and emotional load. Triage decisions, long hours, and high-stakes judgment fall on individuals with limited authority to change the system itself. Burnout, moral injury, and fatigue are structural consequences, not personal failings. Communities absorb strain too. Rural hospitals operate with thin staffing and limited capacity. Urban safety net hospitals serve the most complex populations with the fewest resources. When one facility closes or reaches capacity, pressure is simply shifted elsewhere, often without public recognition. And yet, over time, this strain becomes normalized. Hallways fill, delays become routine, and improvisation becomes standard operating procedure. What begins as crisis quietly becomes baseline. We're not here to assign blame, propose fixes, or debate policy. Our goal is to observe and understand. By recognizing who carries the consequences, we can begin to see the human cost of urgency, the weight borne by those least able to absorb it, and often the weight that goes unnoticed entirely. In the next and final piece of this mini series, we'll step back in the kicker to reflect on why these realities are so difficult to talk about honestly. Stay with us. Who absorbs the consequences when waiting isn't an option? Part 4: Who does what and why it matters. Before we talk about costs, delays, frustration, or reform, we need to pause and do something that rarely happens in public conversations about healthcare: define the system. Most of the anger and confusion people feel about healthcare doesn't come from bad intentions or unreasonable expectations. It comes from assuming that healthcare is a single thing, a place, a person, or a service, when in reality it's a collection of distinct parts, each designed for a specific role. When those roles blur, frustration follows. This week is not about blame. It's about understanding how the pieces fit together, and just as importantly, where they don't. Primary care. Continuity and coordination. Primary care is designed to be the foundation of the system. Its role is not urgency, it is continuity, preventive care, managing chronic conditions, tracking changes over time, coordinating referrals and follow ups. Primary care works best when it knows you, your history, patterns, risks, and medications. It is the long view of healthcare. When primary care access is limited or delayed, pressure builds elsewhere in the system. Urgent care, episodic and limited by design. Urgent care exists to handle non-life-threatening issues that can't wait, but don't require hospital-level resources. Examples include minor fractures, infections, wounds requiring stitches, sudden but stable symptoms. Urgent care is intentionally narrow. It is not meant to replace primary care, and it is not designed to manage complex or escalating conditions. Its value is speed and accessibility, not depth. Because its boundaries aren't intuitive, urgent care is often misunderstood. Emergency departments, stabilization, not ongoing care. Emergency departments are built for one purpose: stabilization. They exist to address life-threatening conditions, severe trauma, rapidly deteriorating symptoms, situations where delay could cause permanent harm. Emergency medicine is about minutes and hours, not weeks or months. It is not designed for continuity, follow-up, or long-term management, even though it is often asked to fill those gaps. This distinction matters more than most people realize. Specialists. Depth without context. Specialists focus deeply on specific systems or conditions. They provide expertise, not oversight. Narrow scope, referral-driven access, high value in defined situations. Specialists are essential, but they rely on other parts of the system to provide coordination and context. Hospitals, systems, and networks, not the same thing. One final distinction that often gets overlooked. Hospitals are places where care is delivered. Health systems manage multiple facilities and services. Networks manage contracts and access. These are operational and organizational layers, not clinical ones, but they shape how care is delivered and accessed. We'll come back to why that matters later. Why this structure matters. When one part of the system is missing, overloaded, or inaccessible, pressure shifts to another part, often one that was never designed to handle it. That's not chaos. That's predictable behavior in a complex system. In the next post, we'll look at one of the most visible consequences of this mismatch: why emergency rooms are overwhelmed, and why it's not as simple as blaming patients. Part 5: Why emergency rooms are overwhelmed and it's not abuse. Emergency rooms are often described as being overused or abused. It's a familiar claim, and an easy one. But it's also an incomplete explanation that misses how people actually experience healthcare when something feels wrong. To understand why emergency departments are overwhelmed, we need to look at how decisions are made in real time, not how they look in hindsight. The decision most people are asked to make. Imagine a sudden health issue. Pain is increasing. Swelling is obvious. The cause isn't clear. It's happening now, not next week. Is this urgent care? Is it the emergency room? Is it safe to wait? Most people were never taught how to answer those questions. Take something as simple and as ambiguous as a spider bite. It's swelling. It looks alarming. It hurts more than expected. Infection is a possibility, but not a certainty. Is that urgent care or the ER? For most people, the safest choice feels obvious. Go where help is guaranteed. That instinct isn't misuse, it's risk avoidance. What emergency rooms are required to do under federal law, EMTALA, emergency departments cannot turn people away based on ability to pay or perceived severity. If someone shows up, they must be evaluated and stabilized if necessary. That obligation is essential, but it also means ERs become the default safety net when other options are unclear, unavailable, or delayed. Why the ER becomes the catch-all. Several structural factors push people toward emergency care. Limited primary care access, especially after hours or in rural areas. Urgent care boundaries that aren't well explained or intuitive. Insurance rules that complicate same-day care elsewhere. Fear of missing something serious. When symptoms escalate quickly, in those moments, people aren't choosing the ER because it's convenient. They're choosing it because it feels responsible. The mismatch. No one talks about emergency medicine is designed for stabilization, not continuity. That means the problem is addressed, not managed. Long-term follow-up happens elsewhere. If it happens at all, the ER absorbs pressure created upstream in the system. When primary care access shrinks or urgent care becomes ambiguous, emergency departments feel the strain. This isn't random, it's predictable. Reframing the conversation. Blaming patients for showing up doesn't fix overcrowding, it just ignores why they came in the first place. Most ER visits that later get labeled non-emergent only look that way after a clinician has evaluated them. Before that evaluation, uncertainty is real and fear is rational. Understanding this doesn't excuse system inefficiencies, it explains them. In the next post, we'll untangle another common source of confusion, the assumption that insurance is the same thing as healthcare, and why that belief quietly shapes access, delays, and frustration throughout the system. Part 6. Insurance is not healthcare. One of the most persistent misunderstandings in healthcare is the idea that insurance and care are the same thing. They're related, but they are not interchangeable. This confusion shapes expectations, frustration, and even how people judge their own experiences inside the system. What healthcare actually is. Healthcare is delivered by clinicians, facilities, equipment, time, coordination. It exists where people practice medicine, provide treatment, and manage illness. None of that is created by an insurance card. What insurance actually does. Insurance is a financial tool. Its purpose is to spread risk, manage costs, decide how and when payments occur. Insurance does not diagnose, treat, or heal. It determines coverage, not care. That distinction matters more than most people realize. Why coverage doesn't equal access. Having insurance does not guarantee timely appointments, available specialists, nearby providers, approval for recommended care. This is why someone can be insured and still struggle to receive treatment or wait weeks or months for services that feel urgent to them. The system is working as designed, even when it feels broken. Prior authorization and delays. Prior authorization is often described as interference in medical decisions. In reality, it is a cost control mechanism built into insurance design. It exists to answer one question: will we pay for this? That question may align with clinical judgment, or it may not. But it is fundamentally financial, not medical. Understanding that difference doesn't make delays less frustrating. It does make them less confusing. Why this confusion persists. Insurance became tightly coupled to healthcare access over decades, especially through employers. Over time, the two concepts blurred in the public mind. As a result, denials feel personal, delays feel arbitrary. Frustration is aimed at clinicians who don't control the process. This misdirection erodes trust on all sides. A clearer way to think about it. Healthcare delivers care. Insurance controls when and under what conditions that care is paid for. They interact constantly, but they are not the same system. Recognizing that difference is essential before we talk about costs, efficiency, or reform. In the next post, we'll look at a layer of healthcare most patients never see, but pay for every day: the administrative machinery that operates between care and payment. Part 7: The Invisible Layer: Administration. Most people experience healthcare through exam rooms, waiting areas, and conversations with clinicians. What they don't see is the layer that sits between care and payment, the administrative machinery that keeps the system running. This layer is largely invisible to patients, but it shapes cost, access, and workload in ways that are hard to overstate. What administration actually means: healthcare administration isn't a single office or department. It's a web of functions required to make modern healthcare operable. Billing and coding, insurance verification, compliance with federal and state regulations, documentation requirements, quality reporting, audit preparation, contract management. None of these activities deliver care directly, but nearly all are mandatory. Why? So much paperwork exists. Healthcare is one of the most regulated industries in the country, and for understandable reasons. Safety, fraud prevention, privacy, and accountability all matter. Over time, however, layers of rules, reporting requirements, and payer-specific processes have accumulated, often without coordination. The result is a system where the same information is entered multiple times. Different insurers require different formats. Documentation is written for billing as much as for care. This complexity doesn't disappear just because patients don't see it. The staffing reality: most people don't know. It's common for a single physician to require multiple non-clinical staff members to support their work. These roles may include billing specialists, coding experts, authorization coordinators, compliance staff, administrative support. This isn't inefficiency in the casual sense, it's the operational cost of navigating a fragmented system. How this affects the exam room. Administrative demands shape clinical care indirectly. Less time per patient, more time spent on documentation. Delays caused by approvals and verifications. Burnout among clinicians who trained to practice medicine, not paperwork. Patients feel the effects even if they never see the cause. A quiet but important point. When healthcare costs rise, it's tempting to assume the increase comes from tests, treatments, or clinician salaries. Often, it doesn't. A significant share of growth occurs outside the exam room, in the systems required to document, justify, process, and pay for care. That reality doesn't assign blame, but it does challenge assumptions. In the final post of this week, we'll step back and look at the system from the patient's perspective: what people are implicitly expected to know, but are almost never taught when navigating healthcare. Part 8: What patients are expected to know, but aren't. By the time someone interacts with the healthcare system, they're often expected to make decisions that would be difficult even with training. Which setting is appropriate? How urgent is urgent? Who coordinates what happens next? These expectations exist, but the instruction rarely does. Decisions patients are quietly asked to make without formal guidance, patients are expected to know. When primary care is appropriate, when urgent care makes sense, when the emergency room is necessary, how referrals work, why timelines feel slow, why follow-up can be fragmented. Most people learn these rules only by experiencing them, often during stressful or painful moments. Why the boundaries aren't intuitive: symptoms don't arrive labeled. Pain, swelling, fever, shortness of breath, or sudden changes can feel alarming even when they aren't life-threatening. And sometimes they are serious. From the patient's perspective, the cause is unclear. The risk feels personal, waiting feels irresponsible. In that context, choosing the most comprehensive option available often feels like the safest decision. The hidden expectation. Healthcare systems often assume patients will navigate access points correctly, understand which services are limited, know when to escalate care, interpret delays accurately, but those expectations are rarely communicated clearly, consistently, or at all. That gap isn't a personal failure, it's a design problem. When "I'm not sure" is the honest answer. There are times when the right response truly is uncertainty. Symptoms evolve, conditions change. Risk isn't always obvious in the moment. Acknowledging that reality doesn't weaken the system, it humanizes it. A system that relies on perfect decision making from untrained users will always struggle. Why this matters. When patients are expected to navigate complexity without guidance, emergency rooms absorb uncertainty, frustration grows, trust erodes, blame replaces understanding. Clarifying roles and expectations doesn't solve every problem, but it reduces unnecessary friction throughout the system. Closing the week. This week wasn't about solutions, it was about structure. Understanding how healthcare is organized and where expectations break down is the foundation for any meaningful discussion about cost, access, or reform. Next, we'll move forward carefully.
Why we struggle to talk about the unavoidable. Welcome to the final moment in this mini-series, Healthcare in America, When Care Can't Wait. What we've just seen, urgent care, strained systems, and the people who bear the consequences, is uncomfortable. It's uncomfortable because it is real, unavoidable, and profoundly human. Most conversations about healthcare skip this moment. We jump to policy, budgets, and blame. We treat crises as exceptions rather than as signals. But the truth is that someone always absorbs the weight when care can't wait. Patients, families, frontline providers, and entire communities share the burden, quietly, unevenly, and often invisibly. This series isn't here to solve the system in 3 episodes. It's here to notice it, to observe it, and to name what exists. By doing so, we give ourselves a chance to engage with it honestly, without illusions, without slogans, and without pretending the weight disappears. Sometimes the first step toward understanding is simply acknowledging reality. That is what this series hopes to do. Hold a mirror, pause, and recognize the unavoidable. Kicker: why we struggle to talk about the unavoidable. Outline healthcare is easiest to discuss when it's optional, scheduled, or abstract, but urgent care does not wait for comfort, familiarity, or convenience. It arrives whether systems are ready or not. It exposes where efficiency falters, where responsibility is invisible, and where human effort quietly fills the gaps. Most conversations skip this moment. We move straight to policy, payment, or blame. But urgent care forces us to acknowledge a truth we often avoid. Someone always absorbs the consequences. Sometimes it's the patient, sometimes the family, sometimes the provider, and sometimes the community. The system distributes nothing fairly, it simply continues. This is why the subject is hard to discuss honestly. It carries no simple solution, no tidy numbers, no clear hero or villain. It's uncomfortable because it is real, unavoidable, and profoundly human. The point of this series is not to fix healthcare in 3 weeks or 6 episodes. It is to notice, to observe, and to respect what exists when care can't wait. By naming this reality clearly, we give ourselves the chance to approach the next questions with eyes open, not blindsided by ideology, not distracted by slogans, but aware of the pressures, the trade-offs, and the human work the system requires.